Alright, welcome back. So last time we left off at question number 21 right here. We were doing actually really good progress trying to get through all the explanations. It was pretty dense material. NBME 22 is pretty nice. I like the questions they have. They teach you pretty well. And remember from the first video I talked about a bunch of things. So one of the things was the page numbers you see here. The first page is actual first aid, and then the 474, that's my personal annotated first aid page number. And one of the ways for studying for step 1, and if you're studying for NBME specifically, always keep in mind it's that you have to go find these types of explanations or make these types of explanations for any question you do, right? If the explanation is not given, or if you're doing NBME where they don't give you explanations, you want to make sure you do this for yourself, because when you do this research, you put together the explanations and explain why the other answer choices are wrong and stuff like that, you connect the dots, you really expand how much you know about something. So we did question number 20 last time. We talked about the genetics here. We talked about how in autosomal recessive questions you have to remember 2/3, right? The 2/3 was a giveaway. Without the 2/3 part, you would not be able to solve that question. So that was good. We can keep going now. So this is number 21. 65-year-old man starts using topical fluorouracil for treatment of actinic keratoses on his scalp. Fluorouracil is most likely effective for this patient because it inhibits which of the following enzymes? So this question is directly a question about the mechanism of action of 5-fluorouracil. And you have to remember a couple things about 5-fluorouracil and methotrexate. They're both very high yield medications. 5-fluorouracil actually uses leucovorin and thymidylate synthase when they connect with each other, and actually stops that complex from working. Right? So that means that leucovorin or folate actually enhances, right? Folic acid actually enhances the activity of 5-fluorouracil, because you need thymidylate synthase and fluoric acid to kind of combine, and then 5-fluorouracil stops that complex. So the answer here was obviously C, thymidylate synthase. They tried being a little cute with, answer choices A and B, but those are both wrong. You also need to know that 5-fluorouracil is capecitabine, right? Capecitabine as a prodrug. Then it becomes 5-fluorouracil. It inhibits DNA synthesis by stopping this enzyme, thymidylate synthase, and reducing DTMP synthesis. Remember that hand-foot syndrome is a blistering ulceration that occurs as a side effect. I've actually never seen a question about it, but I did insert pictures of that on my annotated version right here. So something like this, right? They tell you plantar erythrodysesthesia, palmar plantar erythrodysesthesia is just a blistering ulceration of the skin with normal activities, something that occurs in patients who are taking 5-fluorouracil. So you can see 5-fluorouracil stops thymidylate synthase, where after it combines with folic acid. Methotrexate, on the other hand, actually inhibits dihydrofolate reductase, right? And in methotrexate, the activity of folic acid is something different. Here, leucovorin is actually used to help patients with the adverse effect of myelosuppression. Right, so folate is often given with many chemotherapy and many other medications, even a couple of antiepileptics, because of the side effects some of those medications can have where you run out of folic acid. But in 5-fluorouracil, the reason for adding leucovorin is very unique. You're adding leucovorin to actually help 5-fluorouracil do its job. All right. So that was question number 21. 22 here is, okay. So a 73-year-old man has difficulty urinating and frequent urination. Improvement of these symptoms is most likely to result from treatment with a drug that blocks which of the following labeled sites, right? So difficulty urinating and frequent urination, right? Your initial thought when you read something like this might be that this is urinary incontinence, right? But then you have to remember this is a 73-year-old man, right? Urinary incontinence is usually a female, right? Because of delivery and changes in estrogen levels after a certain age. But a 73-year-old man that's just having difficulty urinating and frequent urination, that sounds a lot like BPH, right? So that's where you had to kind of derive your answer from, because they actually have all the receptors you could possibly think of for both case scenarios in this image. So here the correct answer was E, which is the alpha-1 receptor, because that's related to BPH. This really old man has difficulty urinating, which is enough to understand and assume he most likely has BPH, benign prostatic hyperplasia. Each time he needs to pee, he's unable to get it all out and needs to keep returning to the toilet. Alpha-1 blockers like tauruzosin, doxazosin, those guys can help with the urinary symptoms of BPH. H was the other answer choice a lot of people picked, acetylcholine, right? They're asking you a drug that would block, right? So blocking alpha-1 would be nice for BPH. Blocking acetylcholine is a different thing. So oxybutynin or tolterodine, right? These are drugs that are used to treat urinary incontinence by blocking muscarinic M3 receptors of acetylcholine. That leads to improved urinary retention. But they did not mention any incontinence, and he is not leaking. I had a whole lecture separately within the renal videos. I think it might be renal 12 or 11, one of those. It's specifically just about urinary incontinence. One of the mainstays of urinary incontinence was always some sort of leak, right? There's no leaking. It's not urinary incontinence. He is not leaking. He just has difficulty urinating, and because of that difficulty, he needs to keep trying, which is the frequent urination. All right. So very important to be able to differentiate those two things. And age, remember, is always given, almost every question, and is usually the first thing being given to you about any patient that they introduce. And it's very important to make sure that you use that to your knowledge to really be able to figure out what might be wrong with the patient. So it's very important to be able to make that kind of distinction about things. Otherwise, it's very easy to fall into other answer choices. Okay. All right. 23. So a 32-year-old man comes to the physician because of a 2-week history of persistent thrush. He has been receiving a multi-drug regimen, including zidovudine, for 3 years, but he has had difficulty with compliance. So sounds like an HIV patient. Lab studies show a CD4 positive T lymphocyte count of 100 millimeters cubed and plasma HIV viral load of 100,000 copies per milliliter. So it really doesn't look like he's doing that well with medications at all. HIV genotyping shows a mutation consistent with zidovudine resistance. The mutation is most likely in which of the following viral genes? So this is basically a question about mechanism of action of HIV therapy. Zidovudine is an NRTI that inhibits nucleotide binding to reverse transcriptase, which is answer choice F. Right? You really wouldn't be picking any of these other answer choices. If we take a quick look at HIV therapy, those medications are actually really easy to understand. Alright, so here is your HIV therapy page 203 of 2019 First Aid. So you have your NRTIs, right? These are the weird medications that have the three-letter denotations to them, and they all have weird names, right? Their names do not match. They don't end in the same thing, but it's okay because these guys are just NRTIs. You're going to have to spend the most time trying to memorize their names, which usually occurs because you were doing a lot of practice questions, right? And you can just keep looking at them often, and you'll eventually remember them. Of these guys, you have to remember tenofovir, the T guy, is the only one that's a nucleotide. The others are all nucleosides. We talked about that difference when we first did biochemistry molecular section. So tenofovir is the only one that's a nucleotide. All of them need to be phosphorylated to become active. That's also very important. And then keep in mind the side effects, right? So you have bone marrow suppression because remember, HIV is kind of like HIV therapy is very similar to trying to do like cancer therapy. There is a synonymous action there because you're stopping something from replicating, and what you're really stopping is your white blood cells, right? You're stopping your white blood cells from trying to kill HIV, right? The reason HIV is so amazing is because HIV keeps having mutations, it keeps changing, so you can never actually make one cell to kill HIV. Right, so your body keeps trying and keeps trying and keeps trying until it gets so worn out, and then you no longer have an immune system, which is now AIDS. So here, you want to make sure that you get these side effects down. The adenosine causing pancreatitis is pretty high yield. I've seen questions on that. All the nucleosides can cause lactic acidosis, which means tenofovir will not. Right? These are just little things that you really want to, over time, memorize. So those are NRTIs. Your NNRTIs, there's only three. It's the DEN, right? Delavirdine, efavirenz, and nevirapine, the DEN of NNRTIs. The efavirenz, with memorizing it like that, it helps you remember that it causes vivid dreams and basically nightmares. So you can get some weird, question where a patient who might have started some HIV therapy is not coming back complaining about nightmares or very vivid dreams, difficulty sleeping, etc. That's going to be because of this medication. Then the easier ones, protease inhibitors, they're all Navir. Integrase inhibitors, they all have Tegra in it, right? So these are pretty easy to remember, not that bad at all. And then the entry inhibitors, and enfuvirtide stops fusion, and miraviroc stops docking. So you have to remember where they target to. Enfuvirtide targets the GP41, miraviroc targets GP120. That's very important stuff right there. Yeah, you can go ahead and email me anytime. Material that can be downloaded. I don't really. Oh, okay, all right. Yeah. Well, welcome to my channel. I sell the PDF I'm using, and you can watch a bunch of my videos to see how the PDF kind of looks. It's got annotations all over it, so you can email me for more information on that. I sell this PDF, and then I also sell my NBME explanation PDFs. And if you send me an email, I'll send you all the details and all of that stuff. Other than that, I have a cheat sheet that I've been creating ever since I first got started with my full FA 2019 playlist, where I go through all the first aid with notes from UWorld, Amboss, and all of that stuff. That cheat sheet is a 2-page cheat sheet of things you're supposed to memorize like 2 weeks before your test, so that you can replicate it as soon as you sit down for your test on the scrap paper you give. So that's something that I also give out, and it's also on my YouTube channel community page. Recently I've been revising it, so I'm gonna be making a new one today. Actually, I'll go ahead and do it after this video, and I'll post it on my YouTube community page so everyone can get it there, as well as on my Facebook page, USMLE Live. So yeah, but welcome to my channel. I hope my stuff continues to help you. Let's see. Okay, all right. So let's go ahead. This question was really cool. I really liked how this question was worded. Very interesting question, very interesting topic, and definitely something a lot of people tend to miss out about. So a 29-year-old woman is brought to the emergency department 1 hour after being injured in a motor vehicle collision. Abdominal exam shows tenderness with rebound. Vital signs are stable. A CT scan of the abdomen shows no abnormalities except for a small amount of intraperitoneal fluid. After 6 hours of observation, an exploratory laparotomy is done because of continuing severe abdominal pain. No abnormalities are seen until the surgeon gently slides his hand behind the liver. Then, all of a sudden, there's a sudden massive hemorrhage from the region of the hand, which is behind the liver, and the patient's blood pressure becomes undetectable within 1 minute, which means it becomes really low. Which of the following underlying lesions is most likely associated with the hemorrhage? So this was sort of a direct anatomy question, sort of also a memorization question. If you remembered the blood vessels and where they are and how they move, which you do need to know from GIT, there's only 2 really big things in GIT: the entire anatomy of the blood vessels, and then all the hormones and how they help you digest stuff, right? Those are the 2 biggest things, and then you have a lot of path. So the answer choice is here, right? Avulsion of the celiac trunk from the aorta. The celiac trunk is in the interior aorta. It's not going to be behind the liver, so it couldn't be that. It is B, but let's look at the other answer choice. It says traumatic transection of the aorta. Again, the aorta isn't necessarily, in that area that they're talking about, and a traumatic transection of the aorta would actually take some sheer force. The aorta is very strong. It's a thick artery. That would take a lot of energy. Traumatic transection of the hepatic artery, traumatic transection of the portal vein, right? Those are the other 2 popular answer choices a lot of people fell for. So apparently this is pretty common according to this link right here. Right? This actually happens pretty commonly, unknowingly, and it's avoidable if you have studied this and know not to put your hand back there. 22 of the 25 deaths were caused by blood loss in this manner. 2 patterns of hepatic venous injury appeared to predominate, either avulsion of the trunk of the right hepatic vein from inferior vena cava, or avulsion of the upper branch of the right hepatic vein. These are the things that are from the article I just shared. This was really only between B or E. It couldn't be D either. The inferior vena cava and aorta are retroperitoneal, which helps understand that it could not be C, right? Traumatic transection of the aorta. The celiac trunk is not behind the liver, but rather under it, giving the hepatic artery. Choice E, the portal vein, is also behind the liver, but more under it than behind it, and it's very big and strong. Right? This is what we're looking at for our question, right? You see the hepatic veins coming from the inferior vena cava. These hepatic veins are behind the liver. We're actually looking at the liver from behind right now. And these are the vessels, these are the veins that this physician mistakenly kind of injured, causing, the presentation in this patient. So let's take a quick look at that GIT anatomy for a second. Right, so right here, first thing, you have one answer choice that says hepatic artery, right? We have to remember that the hepatic artery is in here, right, inside your hepatoduodenal ligament. It's part of the portal triad, so that couldn't be the answer. Your portal vein is also in the same triad, right, within that ligament. So that E could not be an answer either, right? So D and E were both inside the portal triad. They're both part of the portal triad, and they're both inside the hepatoduodenal ligament. Not artery, vein. Oh, artery too. What am I saying? They're all in here, right? Portal vein, proper hepatic artery, yeah, and common bile duct. So the portal vein, which is answer choice E, and hepatic artery, which is answer choice D, they're both inside the hepatoduodenal ligament. They're both under the liver, not behind it. So neither of those could have been the answer, right? Those guys are right here. So that was immediately stuff you could knock out if you remembered that ligament, which you definitely need to remember because of the Pringle maneuver. And you know it can't be A or C either, and you would just pick B even if you weren't too sure. So this was technically an easy question, but a lot of people were very confused. And that happens. That's kind of what happens. No matter how well you know a certain topic, when you sit down for the test and you've done a lot of questions back to back, one after the other, eventually you're going to get fatigued out where at some point you're going to feel like, easy things start looking pretty hard to you. 25. So here, 26-year-old woman develops hypotension and hemoglobinuria after receiving 1 unit of packed red blood cells. Which of the following are the most likely to be involved in her condition? All right. So what they didn't do in this question is they didn't give you a time period, right? But you know that this is a reaction to getting the packed red blood cells. Hypotension and hemoglobinuria, these are signs of blood lysis, right? So you look at all your answer choices. Antibody and complement are answer choice A, and that's actually the correct answer. That's immediately what you should pick. B, circulating immune complexes, complement, and neutrophils. Again, B could be a possible answer choice until they put neutrophils. Neutrophils do not make sense. Cytotoxic T lymphocytes, IgE mast cells, or lymphocytes and macrophages are all wrong. This patient has hemoglobinuria 1 hour after a transfusion. Now, they didn't give you the 1 hour, but that's most likely what happened. This is acute hemolytic reaction due to ABO incompatibility, a type 2 hypersensitivity reaction. Antibodies will induce complement activation, right? Knowing and mastering your transfusion reactions and your transplant reactions is actually not that hard. You can definitely do it in 1 day. Just remember, it doesn't even take the whole day. You can do it very easily. Our patient is presenting with this one right here, acute hemolytic transfusion reaction. All right, so intravascular hemolysis, and the patient will end up having hemoglobinuria, which is the mainstay here, as well as hypotension. Okay, fever can be seen too. They didn't give you that in that question, as you have to remember, NBME questions don't really give you much, as you could tell. This is a very minimalistic question. They didn't give you anything. They gave you enough to have an idea of what's happening, but not much else is given. All right, so that's our patient. Also remember the errata for allergic or anaphylactic reaction. There's no fever. Fever was written here previously. I removed it. The other one, febrile non-hemolytic transfusion. So it's non-hemolytic, which means you would not have hemoglobinuria, but you do end up having, fever, headaches, chills, and flushing. Okay, so that's something very flu-like. You'll get some flu-like symptoms after a transfusion. That's this one. And the transfusion-related acute lung injury, this one you're supposed to catch. There's practice questions down here that you can pause and check out from other NBMEs if you wish. But the transfusion-related acute lung injury is basically going to be respiratory distress and non-cardiogenic pulmonary edema, which means that you're going to have pulmonary edema, but it's not because of heart failure. It's not because your left heart isn't pumping correctly. It's pulmonary edema because you have donor anti-leukocyte antibodies, right? The donor blood, the blood that you're putting into the patient, has anti-leukocyte antibodies against the recipient's neutrophils and pulmonary endothelial cells. Right? So not the most common thing, but definitely a very easy question that you don't want to miss. Right? And everything's going to be bilateral too. Both lungs are going to be involved because blood goes everywhere. 26, a 74-year-old man with emphysema and lung cancer is brought to the clinic by a social worker because of his wasted appearance. His wife of 50 years died 8 months ago. He is impoverished and his diet consists primarily of cereal and toast. He has lost 30 pounds in the past 6 months. He has temporal muscle wasting, sunken eyes, loose skin, and edema of the lower extremities. He appears despondent and withdrawn. Serum albumin concentration is 2.5. An X-ray of the chest shows a large mass in the hilum of the right lung. Which of the following best explains the edema? Right. So they gave you a bunch of stuff. They painted a big clinical scenario for you, and they just want to know why this patient has edema. That's actually a very easy question. They made it harder by putting the answer choice as a weird thing. Right? The correct answer here was negative nitrogen balance. Now, if you've never seen this nitrogen balance stuff before, then it's pretty common in NBME. There was another NBME question that also had nitrogen balance in the concept. In fact, I believe that question was about nitrogen balance. Like the whole question was just about that. Here your answer choice is negative nitrogen balance. Why negative nitrogen balance? So nitrogen balance is basically protein balance, how much amino acid you have, right? Nitrogen balance is a measurement of protein metabolism in the body. A negative nitrogen balance indicates muscle loss or protein loss, as increased amounts of amino acid are being metabolized to produce energy. This increases the amount of nitrogen secreted from the body. Because the amount of nitrogen you are taking or eating is less than the amount of nitrogen you are secreting, you have a negative nitrogen balance, right? It doesn't look like he's eating well, and they tell you his diet, right? Just cereal and toast, which really isn't high in protein at all. This man is malnourished, edematous, cachectic, and has hypoalbuminemia. These clinical findings point to protein malnutrition or kwashiorkor disease, which causes edema due to decreased serum oncotic pressure. Right, that was the obvious thing that was happening to this patient, which is why he has edema. This patient must be depressed, and on top of that, he's also suffering with cachexia. Glycogen stores get depleted the fastest and would not explain the edema. Lipolysis and starvation ketosis are the same thing and do not explain the edema. Right? Remember how starvation ketosis, remember the keto diet and stuff like that, the way it works is you starve yourself of all carbohydrates, and then your body starts breaking down lipids instead of carbs because there's no more carb intake, and you start losing weight, right? That's the simple way starvation ketosis works. So starvation ketosis and lipolysis are basically theoretically the same thing as far as this question is concerned. Anabolic state, right? Answer choice A, that's a good thing, right? Anabolic state is a good thing. That's basically insulin. Insulin is anabolic, and that's a sign of you eating. That's a sign of growth, right? So definitely not anabolic state. I'm sorry, guys. Let's see. Davish is asking. It's okay to go off topic. That's fine. I have heard of the PASS program, and I don't recommend it. But I usually don't recommend any programs because, one, it would be unfair for myself because I have my own YouTube channel. But to be entirely honest, the PASS program, it's very expensive. I don't find my theory with education has always been that it should be free because that's kind of how humans should be. This is why my YouTube channel is free. This is why I don't really charge for anything else besides my own hard work that if you want to buy. Otherwise, the YouTube channel, everything is free here, right? It's supposed to be free. Now, the PASS program, although it's successful and has a lot of students and stuff like that, even UWorld, look at how successful it is. Everyone technically buys UWorld. The prices remain high, which I am always, personally against. On top of that, it's a good program, but I think there was another student I once had who did do the PASS program, wasn't so happy with it, and then I had to start telling people that it's not the best thing. So it's really up to you. If you're interested in doing the PASS program, definitely do your research. Always do your research before signing up for any big program, especially things like Kaplan. Kaplan is another one that I'm very anti-Kaplan because I don't really appreciate the way they take all your money but don't necessarily prepare you for step one very well. at the end of the day, the only person that can truly prepare you for step 1 is just yourself, your own hard work. And then Stay Positive asked, how good is AMBOSS for step 1? I really liked AMBOSS. I actually have a lot of notes from AMBOSS in my book now, which is why I do the full FA playlist, because AMBOSS, what they did was, one, I like that they're not assholes about you copy pasting, which is really nice, so you can save notes very easily. On top of that, the images they have, right? So, for example, in respiratory, they have such nice x-rays, and what they've done with their x-rays is they kind of highlight what you're supposed to be able to see, which is beautiful, because, through med school, you're not really going to learn much about, understanding x-rays so well. And this is the stuff from them, right? So you can see here, they do this kind of stuff. They give like an overlay over the x-ray, and they show you what you were supposed to see. Right? So this is like the normal, and then when you finish the question, then you look at the explanation, and that's the explanation on the left. Right? So they really break it down for you. I really liked their x-rays. I really liked how they maintain the professional outline of a question, very similar to step 1, but then they've worded questions very differently from how UWorld has. So instead of repeating UWorld, now it's really nice that you can finish all the UWorld, repeat your incorrects or whatever you flagged, and then move on to AMBOSS, so you don't burn out repeating the same stuff over and over. I have the latest stuff. I have UWorld questions that are from when I was studying, so older stuff, and then I have a bunch from the newer stuff because I found newer UWorld questions when I was tutoring more recent students. So that's everything's kind of all over the place. All right, so let's see now. All right, so that's your nitrogen balance stuff. All right, so this was just D. Now over here. So, number 27. A 22-year-old woman who is at 16 weeks gestation has decreased serum concentrations of alpha-fetoprotein and unconjugated estriol and an increased serum concentration of human chorionic gonadotropin. So she is pregnant, which is why she has ACG. Low alpha-fetoprotein is a giveaway, right? And then estriol further adds on to that. Which of the following disorders affecting the fetus is most likely? This is just Down syndrome. So it's a very easy, nice question. Really nothing to be confused by, but if you haven't studied it, then you might be slightly confused. All right, so trisomy 21, you're going to have beta ACG because this is actually not a good pregnancy, but a viable pregnancy. The baby will be born and will live, as opposed to 18 and 13, where the babies are usually born dead or they die within the first year. Right, so beta ACG, you can see, is not high in 18 and 13. They love giving you that. They'll tell you beta ACG is not high, but the woman is pregnant. She is pregnant, okay? It's a trisomy 18 baby. PAPA is always low, right? And you should remember what PAP-A stands for. I think I wrote it here somewhere. No, I don't have it. I forgot what it stands for too now, but you should look it up because they often like to just put this first, the PAP part about it. Let's look it up right now real quick. PAP-A is pregnancy-associated plasma protein A. Right, it's really easy to remember that. If you see it in a question, you'll kind of know what that is. That's always low because I just remember that as dad. Papa is not going to be happy about any of these pregnancies. Now, in our question, they gave us the fact that estriol is low and alpha-fetoprotein is low. Right, which is true for basically 21 and 18. Right, so it's sort of always true. They asked you what's most likely. 21 is more common than 18. Right, and the differentiating factor between 21 and the others is from beta ACG and inhibin. Inhibin is also high in 21. Okay, in our question, they didn't have 18 or 13 really. So yeah, you would just pick Down syndrome and you'd be done. Yeah, I have questions from the 2017 UWorld as well as the more recent UWorld questions that came out. I usually find them when I tutor newer students or if I see them like on various forums, if they're on the Facebook pages or something, then I try to insert them into the book too. Alright, so now 50-year-old man comes to the physician 3 days after his first generalized tonic-clonic seizure. He has a 1-month history of frequent episodes of a pins and needles sensation around the mouth and in the hands and feet. He also had occasional episodes of involuntary contraction of the muscles of the hands or feet, leading to wrist flexion or foot plantar flexion. Okay. Pulse is 80, blood pressure is 150/90. Neurologic exam shows mild diffuse hyperreflexia. An abnormality of which of the following serum electrolyte concentrations is the most likely explanation for his symptoms. So the hyperreflexia, right, diffuse hyperreflexia, and they want to know if serum electrolyte concentration. If you're thinking about flexing, you should just go with calcium and just move on. That's kind of what's happening in this patient, and it was calcium. This question gets at whether or not you can recognize Trousseau's sign and Schwastek's sign in kind of an unusual presentation. Those two signs are discussed in endocrine. Basically, you get muscle twitches in the setting of hypocalcemia. Hypoxemia further exacerbates the sign and can cause twitches randomly throughout the body. Schwastek's sign is tapping on the facial nerve of the facial nerve of the face, of course, which elicits a facial muscle spasm. And then Trousseau's sign is when you put a blood pressure cuff on a patient. This causes cells in the arm to not receive blood, which is the hypoxemia, right? So no oxygen, no oxidative phosphorylation, decreased ATP, failure of the sodium-potassium pump, increased intracellular sodium and calcium, and that now leads to decreased serum calcium, which causes flexion of the hand. Right? So this is kind of seen everywhere. This isn't just here. You can also get questions about a patient with an MI, right? So now you have dead cardiomyocytes. Dead cardiomyocytes also have failure of the sodium-potassium pump. So they have increased intracellular sodium, increased intracellular calcium, all of which causes more issues and edema and whatnot in those patients as well. Right? Trousseau's sign is more sensitive for hypocalcemia, but both are diagnostic. Other tips in this question are the tingling around the mouth, hands, and feet, which are also possible signs of hypocalcemia. Both generalized tonic-clonic or focal motor seizures can occur with hypocalcemia. Right? So this was really a patient presenting with hypocalcemia. Right? 1 month history. Okay, so nothing beyond insane. No real reason to pick potassium or sodium here, or bicarb or chloride. So I couldn't really think of any logic for picking any of those other answer choices. Here, a 50-year-old man who has smoked 2 packs of cigarettes a day for 34 years has experienced gradually increasing shortness of breath on exertion, chronic cough productive of thick sputum, and frequent episodes of wheezing. The anterior-posterior diameter of his chest is increased, which is a sign of emphysema. He might have COPD. Diminished breath sounds and scattered rhonchi are audible throughout the lung fields. Which of the following lab abnormalities is expected in a patient with COPD? Right, that's basically what the question is. What lab abnormality do you expect in a patient with COPD? So you look at all these choices. Decreased blood PCO2. PCO2 would decrease in the blood, right? Which would be a sign of metabolic alkalosis if you were hyperventilating, and that's not something people with obstructive lung diseases do. Increased blood bicarbonate, that's the correct answer, but let's look at the others. Increased blood pH, so this would be a sign of CO2 retention in a way. Increased urinary excretion of bicarb, and increased urinary pH. Now, urinary stuff, just to be clear, urinary stuff is usually a sign of some kind of renal issue, right? Our patient doesn't have a renal issue. So both of these answer choices don't necessarily make that much sense. Emphysema leads to CO2 trapping, leading to increased PaCO2 in the blood, which is why A is wrong. That gives you respiratory acidosis. Okay, so increased blood pH is wrong. It would be decreased blood pH. Proper renal compensation will increase bicarb reabsorption and decrease excretion, giving you increased bicarb in the blood. So increased blood bicarb was the correct answer here. This is an acid-base physiology question, where the question is no longer about the acid-base physiology itself, but rather the compensation for that, right? Another way to think of this question is that if there is decreased exhalation due to COPD, there's going to be increased CO2. Increased CO2 transported in the blood by entering the RBCs with carbonic anhydrase, and bicarbonate is released into the bloodstream. So increased CO2 leads to increased bicarb, seeing as this type of CO2 transport is 70% of total CO2 content in the blood. Right? 2 different mind maps that could have led to the same answer. Increased blood bicarb. The third mind map would be canceling out over the other answer choice. Decreased blood PCO2 is wrong. Alkalosis, which is increased blood pH, is wrong. Increased urinary pH is wrong. Increased urinary excretion of bicarb is wrong. Why would you have urinary bicarb excretion? Right? That's almost never really a thing. So, that's basically it. And of course, it could be a compensatory mechanism, but then you would have to figure out what are you compensating for? And this is just a patient with COPD, right? So, not that bad of a question at all. Definitely worded in a just fine enough way. You definitely get the diagnosis from the question stem, but it does involve a little bit thinking. It would have been much easier if the answer choice was just increased CO2, but they put increased bicarb, which is pretty synonymous. So be ready for stuff like that. Now you have your brachial plexus. So a 20-year-old man comes to the physician because of tingling and numbness of the dorsum of his right hand for 3 weeks. He has been using crutches for 1 month following a severe ankle injury. Physical exam shows weak extension of the right hand at the wrist and difficulty raising the right arm above the shoulder. This patient most likely has a nerve injury at which of the following labeled locations in the diagram. Increased blood pH. Yeah, increased blood pH is alkalosis. Right? And alkalosis would occur, this is actually interesting. Increased blood pH would occur if you have a lot of blood bicarb, right? Which is why, they put these right next to each other, because a lot of people actually cancel out these answer choices by going like, increased blood bicarb and increased blood pH must both be wrong because they're the same thing, okay? But they're not the same thing. Here, increased blood bicarb is actually occurring to balance out pH, right? It's a compensatory mechanism. Blood pH is actually going to be pretty low, and you're going to try to fix that by increasing blood bicarb, and that compensation is usually not good enough, but it does occur. Yeah, but I can totally see people falling for both, actually. C or D were the other two answer choices that people could definitely fall for. All right, so what's up with this guy, right? So physical exam, he has issues with extension. So as soon as you see issues with extension, you should, almost immediately think of radial nerve involvement, right? And now you just have to remember where the radial nerve was. So your brachial plexus is actually pretty high yield on the NBME. You do need to know your brachial plexus lesions pretty well. So let's take a look at the picture I showed yesterday too. I really like the images I have here, especially this color-coded one, because they do justice to help you memorize what's happening. In our patient, right, the question is with the radial nerve. Now, you can have a lesion here, which would cut off the radial nerve and the axillary nerve, or you can have a lesion only at number 6, which would cut off only the radial nerve, but not the axillary nerve. Right, so those are the two things we're possibly considering. And 6, you have to remember, is Saturday night palsy, which causes wrist drop. Okay, but 3 is the one that's just wrist drop, right? Which is which one? Number 3. Let me see. None of these per se. But one of these. Let me see. Where did they talk about the crutches stuff? I'm trying to remember. No, it's not here. The guy using the crutches. I can't remember what page that was on. But when you use crutches, you kind of cause compression right here in the axilla, and that's kind of what our patient's talking about. They're talking about using crutches for a month. So you see, they have both answer choices here. They have this one here, which would cut off the axillary and the radial, or just radial. Okay, so that's why they gave you the other half of the physical exam. They told you that he has weak extension and he has difficulty raising the right arm above the shoulder, which is your deltoid, right? Remember this, the STDs thing. Let me see. Right here, that's the first thing in musculoskeletal. Well, after rotator cuff, arm abduction, right? STDs, and then the SALT thing is what the book tells you to remember. Right, so SAALT is how I look at the SALT stuff to memorize the nerves. So axillary nerve is related to deltoid muscle, and also sensation in this area, this tiny area right here. So since our patient has both issues, right, abduction and extension, that's going to be C, right? If they told you that physical exam shows weakness of extension of the right hand, but no difficulties with arm abduction over the shoulder, then the answer would just be B, only radial nerve lesion. This patient is using crutches, which compressed his brachial plexus, and now he has symptoms on his hand and difficulty with extension and abduction. Extension is all radial nerve. Abduction is regarding the axillary nerve to the deltoid. The radial nerve can be compressed in Saturday night palsy by sleeping over a chair or due to crunches. Involvement of the axillary nerve makes the answer C rather than B, which is only the radial nerve. Right? B was only the radial nerve. So, excuse me. So not so bad, but definitely a very, very nice question. What was this about? Oh yeah, this was a weird. I got this wrong. This was a weird question. So an unimmunized 1-year-old boy is admitted to the hospital because of fever, irritability, and a stiff neck. Cultures of the nasopharynx and CSF grow gram-negative coccobacilli. Electron microscopic examination shows the presence of pili on the bacteria recovered from the nasopharynx, but absence of pili on the bacteria of the same species recovered from the CSF. Which of the following processes shuts off expression of pili in this bacterium following invasion? Right? So you look at all your answer choices and they all just sound really weird. Of all of these answer choices, the only one you could possibly think of canceling out is the point mutation, and that would most likely only be because you know what a point mutation is. That's what I did. So I canceled out D. I was like, I know what a point mutation is. Doesn't really seems to do anything with this kind of stuff. So point mutation was gone. Transposon mutagenesis. Again, I didn't think it was a mutation, and I felt like mutagenesis sounds like a mutation, genesis of a mutation. So I canceled out E also because this doesn't sound like they're talking about a mutation. This sounds like someone actively, right? These bacteria actively decided to no longer make pili. They didn't need it anymore. They're in the CSF. So D and E were gone. Now, plasmid acquisition, horizontal gene transfer, or phase variation. The cool way to get this question correct was to understand that things have changed, so it's just a phase variation, right? They needed pili when they were in the nasopharynx. Now they're in the CSF. They don't need it. The other thing was you don't really get horizontal gene transfer or plasmid acquisition because there's no other bacteria. It's just them. It's a bunch of guys that were making pili. Now they all decided not to make pili. So it wasn't because one of them gave something to the other or lost a plasmid or something like that. It was because they all actively decided we don't need to make pili anymore and we can save ATP. In biology, there's a whole thing about phase variation. You could go ahead and read it if you really care. And then there's this link from WikiWand that you can also check out if you care. I personally didn't really care too much after this question because it's not really that high yield. This is just, NBME often has at least 4 to 5 questions like this in every exam. It's okay, just use, do your best, check it out, use whatever logic you can, solve it the best you can. Also keep in mind, phase variation is not antigenic variation. Antigenic variation involves genomic rearrangement. Phase variation can be thought of as more or less of something, right? And here it was less of making pili. It's an on-off switch. That's all it is, phase variation. No DNA is being rearranged, just under or overexpression is occurring in response to whatever the environment is. That's it. Diabetic ketoacidosis. So a previously healthy 7-year-old girl is brought to the physician by her parents because of a 1-month history of excessive urination. She also had a 5-pound weight loss during this period. Her pulse is 110, blood pressure is low, physical exam shows poor skin turgor and fruity odor on her breath, which is, as soon as you see fruity odor of breath, you immediately think of diabetic ketoacidosis. Her blood glucose is super high, 612, and lab studies are most likely to show what? So I put all the labs you're supposed to see, right, from my own notes. These are all the labs you're supposed to see in a patient with diabetic ketoacidosis. So you look at all your answer choices. They wanted to know what's going to increase, right? Arterial pH is going to decrease, right, because this is acidosis. So A is wrong. Serum bicarb. Will bicarb increase or not? I don't know. Will chloride increase or not? Not sure. Serum potassium concentration. Now, when you're studying diabetic ketoacidosis, this was actually really high yield. The whole concept of what happens with potassium. Serum diabetic ketoacidosis is directly related to insulin. So you have to remember how insulin works. And a big part of insulin's mechanism of action is putting potassium into cells. Now that this patient doesn't have insulin, right, which is why you get diabetic ketoacidosis, you didn't take your insulin or you're not making insulin, you end up having a lot of potassium outside in the serum. So D is immediately the correct answer, right? But I said I don't know and I don't know about B and C because that's what happens when you haven't really studied that much, right? But it's okay. Even if you didn't know about bicarbonate chloride or sodium, you should definitely be able to figure out that DKA is a lack of insulin. And without insulin, you're not going to send potassium into cells, which means you're not going to be releasing any you're not going to be doing, all the anabolic things insulin is supposed to do, and now you're going to have high potassium in the serum, right? And that's everything you need to know. But again, yes, bicarb will be low because remember pH is low, right? So it wouldn't make sense if bicarb was high. Also remember that diabetic ketoacidosis is something you deal with, right? Diabetic ketoacidosis is a metabolic acidosis, right? So you deal with it with respiratory compensation. So it's not going to be a bicarb compensation here. Chloride was kind of irrelevant, right? So it's not even like here. And sodium is also going to be low, okay? So that's about it. Another thing you can get a question about is ammonium. Ammonium is going to be high. It's one of the only other things that is high, ammonium and potassium. And ammonium being high is significant because that kind of means that the patient no longer needs a buffering system in their body. So that's something you can get a weird question on as well, but not exactly very high yield. 33. A previously healthy 12-year-old boy is brought to the emergency department because of a 6-hour history of severe diarrhea. His temperature is 98.6 F, pulse is 100 per minute, respirations are 16 per minute, and blood pressure is 110/70. He appears markedly dehydrated. Physical exam shows no other abnormalities. The most appropriate treatment for this patient is an oral rehydration solution containing which of the following sets of ingredients? Okay, so severe diarrhea, and now they just want to fix that. How do you fix that? Easiest way to think of this is that this is Gatorade, right? The answer choice is D, glucose and sodium. Right? You just have to, when a patient comes in with diarrhea, if you give them Gatorade, they'll feel a lot better. Everyone thinks that sports drinks have glucose for the energy, which is also true, but they also contain sugar because the sodium glucose co-transporter in the small intestine helps drive electrolyte intake. Without glucose, you don't pull in sodium nearly as efficiently in the gut. And the first makers of the Gatorade formula at UF found that once they gave glucose and electrolytes instead of just water to the football team during practice, they didn't get as dehydrated and their electrolyte balance was a lot more stable. Right, so a nice little thing to kind of put into your understanding. And this is kind of why there's no diet Gatorade per se. You don't get Gatorade without sugar. You need sugar to take electrolytes up. Right? You don't need it, but the sugar helps. Sugar really speeds up how well you take up electrolytes. This guy with severe diarrhea clearly must have lost a lot of electrolytes. He's dehydrated, so he obviously lost a lot of water, right? And other than that, he's not doing too bad. So glucose and sodium was the thing to fix it. Glucose and insulin, as choice C, would more be an answer of, someone who might be diabetic and is very hypoglycemic for some reason. You can give them glucose and insulin. You give them the glucose and then you give them the insulin to be able to use the glucose, right? Other answer choices were just irrelevant here. Okay, so now this one, a 4-month-old boy is brought to the office by his parents because of his small size and difficulty feeding from a bottle. His mother states that he was recently adopted from a developing country and his medical history is unknown. His vital signs are within normal limits. He is at the 10th percentile for weight and 40th percentile for length. Physical exam shows the findings in the photograph. Right, so you can see there's a cleft here. The most likely cause of facial findings involving the lip, the cleft lip, is a failure of normal fusion of which of the following pairs of structures. So this is just straight up embryology, right, development. So how do you get a cleft lip? Cleft lip is due to nasal prominences not fusing. It's very easy to remember that because your nose is right here. If the nasal prominences don't fuse, you get a cleft lip. A cleft palate, the palate is inside your mouth, the upper part, is due to palatine shelves not fusing, right? Which is also easy to remember. They're palates not fusing. That's the answer, palatine shelves. For our patient, the answer is F, right? Maxillary and medial nasal prominences not fusing. Now they got very creative with it. They have a lot of nasal prominences, 3 of them, right? And then others are not really mentioning a nasal prominence. So first thing, well, they are actually. They mentioned it right here. So all of them except for D have nasal prominences in the asterisks. So you can definitely knock out D. And then it was, excuse me, and then it was about mandibular, maxillary, and medial, right? But mandible is down here, so that doesn't really, fit the scenario at all. Maxilla is up here, and your medial stuff is where you're gonna fuse. So it's pretty deducible answer choice, even if you haven't actually ever studied it. So F was the answer here, maxillary and medial. Alright, so now this one is quite a bit, so let's take a look. A 24-year-old woman, G1P1, comes to the physician because of nervousness and tremors since delivering a healthy female newborn 6 weeks ago. She also has had a 5-kilogram weight loss during this period. She has a history of panic disorder and carpal tunnel syndrome. Temperature is fine, pulse is 100, blood pressure is a little high. Physical exam shows a firm thyroid gland that is twice the normal size. Serum studies show a free thyroxine concentration of 2.4, which is on the upper end of normal. TSH concentration of less than 0.03, so TSH is low, and a 24-hour thyroid radioactive iodine uptake of only 1%. Which of the following is the most likely explanation for this patient's symptoms? Okay, so thyroid questions, very high yield in NBME, and definitely a high yield topic for step 1 as well. Diagnosis is usually based off of TSH. If TSH is low, as it is the case for our patient, when TSH is low, that's usually because you have hyperthyroidism, right? Your thyroid gland is making a lot of thyroid hormone, and your hypothalamus is responding by not telling you to make more. But then the other half of diagnosis is this thyroid reactive iodine uptake, which was also very low here. Right, so the answer here was actually C, release of stored thyroid hormone from a thyroid gland infiltrated by lymphocytes. This one was a little tricky. For this one, the key is the low radioiodine uptake. This patient has high T4 and low TSH, which makes sense in hyperthyroid patients, right? Low TSH is a sign of hyperthyroidism, and vice versa. So perhaps your first thought is that this patient has Graves'. However, in Graves', your thyroid is being stimulated to make more thyroid hormone from scratch, and as such would have an increased radioiodine uptake because the thyroid is bringing in the required, now radiolabeled iodine. This is why it's not Graves', which is release of thyroid hormone from a thyroid stimulated by antibodies, right? As choice E, which a lot of people picked. E was not the correct answer here. This is not Graves'. Graves would have a high radioactive iodine uptake because basically any iodine you eat would go to your big thyroid. The thyroid is a factory in these patients. So if it's not Graves', what could it be? For this, you'd have to know that Hashimoto's thyroiditis, which is also chronic lymphocytic thyroiditis, is often referred to as such on board exams to throw you off, and that thing has 3 phases. First, patients are going to be hyperthyroid, then they'll be euthyroid, normal, and then the classic hypothyroid phase occurs where you would expect low T4 and high TSH. Okay, that was the key to this question. You could tell that whatever happened to her recently happened to her, right, because of her pregnancy issues. So if it wasn't Graves', once you figured out it wasn't Graves' and you canceled out E, the only other likely thing is the other common answer choice, Hashimoto. And Hashimoto initially will be hyperthyroid. Okay, and that's what we see in this patient. But what do we see? What are all the lab stuff telling you? We see that she's hyperthyroid, but she's not trying to make more thyroid. Right? When you see that, that's a sign of hypothyroidism. Because eventually, all the hyperthyroid she has is going to get used up, and her hypothyroidism is going to catch up to her. She's not going to have enough thyroid hormone. Her hypothalamus is going to respond by making more TSH, which is when you'll be able to diagnose hypothyroidism. All right. So release of thyroid hormone from a lymphomatous thyroid gland is referring to some kind of thyroid cancer, in which case you would expect them to be describing a nodule on radioiodine uptake, and that was also wrong. That's choice D. Yeah, radioiodine uptake. So forget the radioiodine, just iodine uptake. We eat iodine and salt in America, right? It's infused in the salt already. Iodine uptake is a sign that your thyroid gland is working and making thyroid hormone, right? Because when you eat and you ingest iodine, or you ingest it in any other way, inject it in any other way, that iodine is going to be taken up by the thyroid gland, and your thyroid gland is going to use that iodine to make more thyroid hormone. This patient, when they gave her the iodine, she didn't take it. Like, she's not using it. Most likely, all the iodine that was given to her is just going to come out in feces and urine. That's telling you that she's not actually trying to make more thyroid hormone, right? She can't make thyroid hormone. So her not being able to make thyroid hormone was more diagnostic here than the fact that her T4 was high and TSH was low, right? That's the little trick here. If they don't give you radioiodine uptake, then you can't make that diagnosis. Okay, so that's why they gave it to you. That fact there was very significant. Understanding thyroid labs is very high yield. High TSH or low TSH is a sign of what's happening with your thyroid gland, and then amount of free T4 is another sign of whether you're making too much of thyroid binding globulin maybe, right, or your gland is not making enough thyroid hormone. And then radioactive iodine uptake is a sign of whether or not your thyroid gland is even working, right? And if iodine uptake is very low, your gland is not working. And if your gland is not working, that's a sign of hypothyroidism, regardless of the low TSH and high T4, right? Because that's now you can think, oh, okay, so her T4 is only high right now, but eventually it's going to become low, right? And that's the whole kind of understanding of what's happening. All right, so make sure you remember that Hashimoto is lymphocytic, right? Lymphocytic. This was a pretty weird question. I couldn't really understand what was happening when I do NBME's explanation videos. I solve the questions myself first, and then I tell people when I got something wrong, and I got this one wrong because I couldn't really tell from the terrible picture they picked. A 10-year-old girl has a slightly painful 2mm subcutaneous nodule on her chin. This is the third question I've gotten wrong up to number 36. 10 weeks ago, she required sutures after she lacerated her chin playing basketball. A photomicrograph of tissue obtained on biopsy of the nodule is shown. Which of the following best describes the pathologic features? So I'm looking at it and I don't really necessarily see much, right? I can't really tell what they're talking about. I knew it wasn't A. It's not going to be amyloid. B was something I fell for, right? I thought it might be granulation tissue because now it's been 10 weeks. The answer here was actually granuloma, and that's what you're kind of seeing apparently. And then lymphocytic and neutrophilic infiltrates didn't make sense because I didn't think she had an infection. She doesn't have any kind of infection, right? Bacterial or viral, so that's not going to be correct. Here the answer was just granuloma simply based off of the image. You can see epithelioid and giant cells. The only other feasible choice was granulation tissue, which would be wrong for 10 weeks, right? And that's where my thinking was wrong. 10 weeks is not going to give you granulation tissue. By that time, everything should be normal now. Right? It doesn't take that long, especially at this age, to fix everything, especially skin. So, very interesting question. Definitely remember that granulation tissue does occur, yes, but then it all gets fixed up very, very quickly when you repair skin. Okay, she has granuloma now, which I don't know why she has it, but she has it. They didn't really explain anything else. Definitely a little weird of a question. Doable though, because you do see giant cells and you do see circular things that normally wouldn't be there. But I don't know, I got it wrong, so there's that. 37. 5-year-old boy with mental retardation is grossly obese and has facial features of Prader-Willi syndrome. Karyotyping and fluorescent in situ hybridization studies do not show deletion in the usual site on chromosome 15. Which of the following findings is most likely to confirm Prader-Willi syndrome in this child? So this was a very interesting question because Prader-Willi and Angelman are pretty well discussed topics in the book, but they're asking this question in a very interesting way. So they tell you that the expected thing didn't occur, right? Where a deletion in chromosome 15. So what's the other way you can get Prader-Willi syndrome? That's what the question was about. And the other way you get Prader-Willi syndrome is the maternal origin of both chromosomes 15, right? So you have to remember, how do you even get Prader-Willi syndrome in the first place? Prader-Willi has imprinted maternal genes, and the disease occurs when the paternal allele messes up, right? Imprinted basically means turned off, right? So in Prader-Willi, the father leaves, the father disappears, right? However, 25% of cases are due to maternal uniparental disomy, which is a high-yield topic in biochem, right? Uniparental disomy, which means that you got both copies of turned-off genes from the mom. Okay, so page 58, let's take a look at this for a little bit. So Prader-Willi syndrome, right? Maternally derived genes are silenced or imprinted. Disease occurs when the paternal allele is deleted, right? And that's chromosome 15. Prader has no papa, right? The dad left. So this means two things. Either you have no dad because the dad left, or you have two moms, right? Because a lesbian couple adopted you. Something like that, right? It's a very easy way to think about it. Also remember that since dad is not there, he's useless. So this helps you remember the clinical presentation of a Prader-Willi patient. Imagine a very useless dad that just eats, gets fat, is dumb, has no balls, and is weak, right? Because those are all the symptoms or presentation, right? Hypogonadism, hyperphagia, hypotonia. The other half, Angelman syndrome, is imagine an overworked mom that's going crazy. She just laughs, has seizures, can't stand, and is very dumb. Keep in mind, this is paternal imprinting, and the mother's gene is deleted, right? So there has to be a deletion in the mom. But 5% of cases can be paternal uniparental disomy, where you got both imprinted silenced genes from the dad. Right, so that's all this question was. This is a pretty easy question. Once you read answer choice D, you would just pick it because it makes sense. Right? If it wasn't a deletion in the dad, then that means you must have just gotten 2 silenced genes to begin with. The other answer choices didn't necessarily make sense. I mean, they just told you there's no deletion in chromosome 15, so then A can be correct. Duplication within chromosome 15 would, just give you another chromosome 15, but again, the normal chromosome 15 is already there. So if you duplicate it, that's not going to fix the issue. You still have the same thing. Large trinucleotide repeat expansion. Again, Prader-Willi syndrome is not one of your trinucleotide repeat expansion diseases. And translocation in the short arm of chromosome 15, that was, there's no real way to deduce this answer choice, but after you read D, you would pick D. And that would be it. 38. So let me, okay. Yeah, there's a lot over here. So let's see. Let's read the question first. A 45-year-old man who is HIV positive comes to the physician because of a 1-week history of headaches and blurred vision. A lumbar puncture is done. Lab studies show glucose is 95. Serum glucose is 95, but CSF glucose is 30. Total protein is 68. Fungal stain is positive for yeast, right? So it's a yeast infection. The most appropriate treatment for this patient is a drug with which of the following mechanism of action? Anything that kills yeast. So they didn't put medications here. Okay, so let's take a look at the explanation. The answer here was C, right? The pathogen is going to be Cryptococcus. Treatment options are amphotericin B, which binds ergosterol, causing pores to form in the fungal membrane and leak contents. And you can add flucytosine, which gets converted to 5-fluorouracil to inhibit nucleic acid synthesis. Adding fluconazole for meningitis is also a thing. Here the answer was C though, disruption of the pathogen cell membrane, which you will always remember once you studied microbiology, that to kill yeast, you can always do this, right? Destruction of cell membrane. I put the notes from my book about Cryptococcus, and this is the sketchy micro image of Cryptococcus. And yeah, that's basically it. So this wasn't so bad at all because they gave you the yeast. They told you it's yeast, headaches and blurred vision, it's kind of a sign of meningitis. He has HIV. And so lumbar puncture, further depicting that there is some level of meningitis, and then you just pick C and you move on. That's really all you have to do here. This was an interesting question. This is nice. So number 39, in patients with adenosine deaminase deficiency, there is a 50 to 100-fold increase in DATP concentration in T lymphocytes. This increase in DATP inhibits which of the following enzymes, thus compromising DNA synthesis. Okay, so page 117 discusses severe combined immunodeficiency. The left image shows DATP causing lymphotoxicity in adenosine deaminase deficiency, right here. So you can see ADA, if it's not there, then you can't do this stuff. You can't take deoxyadenosine into deoxyadenosine. ADA's job is to make this transformation to occur. Without ADA, you don't do this. So instead, you go this way down here, right? You make deoxyadenosine triphosphate, which is lymphotoxic. Okay, so you need to get rid of your deoxyadenosine into deoxyinosine, which then goes to purine salvage. The right image shows DATP inhibiting RNR, which is the answer, ribonucleotide reductase. Okay, so here you're kind of seeing normal deoxyadenosine becomes deoxyinosine, which goes through purine salvage, uric acid, done. In ADA deficiency, your deoxyadenosine becomes deoxyadenosine triphosphate, right, DATP. That DATP inhibits ribonucleotide reductase. Why? Because ribonucleotide reductase its job is to make more DATP, right? So this is like a negative feedback thing, okay? The same applies for these other guys as well, GTP, CTP, and TTP, right, for replication. So if you have too much DATP, you're no longer going to do replication. Lymphocytes are replicated regularly. So in ADA deficiency, you end up having lymphotoxicity. You don't make lymphocytes anymore, and now you get severe combined immunodeficiency. The top right image here from your biochemistry section is a snippet showing hydroxyurea's action on ribonucleotide reductase. Right? DATP inhibits ribonucleotide reductase because ribonucleotide reductase makes more DATP. Right? So now you know something you might not have learned about adenosine deaminase deficiency from first aid alone, because first aid doesn't really go that in depth to talk about it. Right? So page 117, they have a small mention. Oh no, this is the actual part where they talk about severe combined immunodeficiency. Right? They don't really talk about what we just talked about though. It's not here. And I put some images. So I put those images into my book too to further explain what's happening with the adenosine deaminase deficiency. It's very easy to understand it now with these two flow charts. Okay, so not that bad, but definitely a question that I can see people getting wrong because it's not really discussed in first aid, and I don't think I've ever heard of this from USMLE RX either or anything actually. But I was able to get this question right because I knew it wasn't A, I knew it wasn't B. Right, those are DNA ligases, or DNA ligase and DNA polymerase. Those guys have nothing to do with DATP. Okay. Then I looked at thymidylate synthase, and I remember that this guy has significance with 5-fluorouracil. Earlier we just did a question, right? 5-fluorouracil inhibits the thymidylate synthase and folic acid complex. So that wasn't right. Now, nucleoside monophosphate kinase is just a kinase. If DATP inhibited that kinase, you would stop doing kinase things, which is to add phosphates to things. Didn't really seem that significant, and you don't really need a kinase for DNA synthesis, but I know you need ribonucleotide reductase for DNA synthesis, so I picked D. Okay, so it wasn't, but I didn't know what I've written here in the explanation. That stuff I found later on. Last question for this video. I do 20 videos at a time, 20 questions at a time now for NBME because it's too demanding to do any more than that. And I also don't want the videos to be too long. This was I-cell disease, right? So patient with I-cell disease lack phosphotransferase required for the formation of mannose-6-phosphate residues that are normally attached to enzymes destined for the lysosome. The mannose-6-phosphate sorting signal is normally added to proteins in the cis-Golgi. Which of the following most likely occurs to the lysosomal enzymes in these patients? What happens to lysosomal enzymes in I-cell disease? That's all they're asking. So that was D, secreted from cells. There was really nothing else to it. You wouldn't pick degraded in the lysosome. Lysosomal enzymes will not be degraded in the lysosome, right? In fact, that's the pathology in I-cell disease. You're not degrading anything in the lysosome because you're not sending it there. Imported into the nucleus is weird. You never import anything into the nucleus. Things come out of the nucleus, but I've never heard of anything being imported into the nucleus. Retained in the RER was a trick answer choice. Lysosomal enzymes will not be retained in the RER. Everything else that was supposed to go to the lysosome, that gets retained in the RER, right? Everything that you were supposed to put a mannose-6-phosphate residue onto so that it would know to go to the lysosome and die, those guys end up being retained in the RER. But lysosomal enzymes, if they retained, if they stayed in the RER, they would start digesting everything, and that would actually get rid of the I-cell disease issue. And then sorted into the mitochondria doesn't make sense either. Why would you sort lysosomal enzymes into the mitochondria, right? So the only other answer choice was that it must be getting secreted from the cell. The mannose-6-phosphate tag would send the proteins to the lysosomes, so that does not happen. Okay. So at that point, the Golgi made these proteins already, but couldn't tag them. So the only other fate is to be secreted via clathrin, right? Lipids, glycosaminoglycans, and carbohydrates in patients who have I-cell disease. It's going to be all in their serum. And there's a bunch of other things you note in them too, which is all discussed in page 47 of first aid. They tell you that it is autosomal recessive. They don't tell you that, but I put it here. It's autosomal recessive. And you note all those things in their blood, and patients usually die because of CHF. All right. They're going to have, this heavily resembles Hurler syndrome too, because they have the coarse facial features, gingival hyperplasia, clouded corneas, right, restricted joint movement, claw hand deformity. The kyphoscoliosis is another thing they can present because of, but generally speaking, fatal in childhood. If you're born with ISL disease, you're probably going to die. Okay, so that's it for now. I'm going to stop over here at question 40, and then in the next session, I'll continue on and go into question number 41. Thank you very much for joining, and I'll see you guys again in the next video.